All right, so what I'm going to do here is I'm going to hand things over to Chris and let him kind of take over. I'll let him introduce himself and we'll go from there. There we go.
All right. Thank you, everybody. Thanks for jumping on here. It looks like we have a great turnout for today. I think we've like over 30 people so far. So you guys are all interested in learning about tendinopathy. So I have to give just a brief overview, just a little bit into the nitty gritty and then some practical things here regarding tendinopathy, and really just, get to dive into that, and then save your questions at the end and we'll go from there. So let's get started with things.
Make sure they can hear you. Oh, okay.
Yep. Okay, so a little bit about me. I'm a physical therapist here with physical therapy at ACAC here, our Prophet Road Clinic, which is right by the airport, right behind Wawa, if you're familiar where that is. I went to Penn State University and I got my Bachelor of Science in Kinesiology, which is movement science, and my doctorate in physical therapy from Shenandoah University, which is just up the road here a bit. I am an American Physical Therapy Association orthopedic certified specialist, and I've been treating here in Virginia for the last 5 years. I specialize in spinal conditions, general orthopedics, and rehab after joint replacement. So the objectives for today really are just to understand the structure and role of the tendon and understand the difference between tendons and ligaments, differentiating between tendinopathy and tendonitis, and reviewing general guidelines for tendinopathy management. So we're going to start out really basic today. What is a tendon? So at its simplest form, a tendon connects muscle to bone. So you may be wondering, I've heard of a ligament. What's the difference? A ligament connects bone to bone. So in a little more detail, tendons are made up of dense fibrous connective tissue, which are made up of collagen fibers that transmit mechanical force of muscle contraction to the bones. Ligaments are a short band of tough, flexible fibrous connective tissue, which connect two bones or cartilage, or they hold together a joint. You can see here in the picture, the tendon is right here, the muscle here, and there's a bone that will be in your elbow. And then the ligaments here are in your hand. They hold together a joint. So one of the most common ligaments you've probably heard of is the anterior cruciate ligament in the knee. So what's in a tendon? Okay, so you're looking at the tendon at a really small cellular level, and you'll see there's collagen, which is protein, carbs, and proteoglycans. So that's really at a cellular level of what makes up a tendon. So we're going to zoom out here a little bit. So this is tendon is a good example of a matrix in which collagen assembles into fibrils, which you can see here on the left, and they aggregate to form fibers, okay? So these are the main structural components. And then you can see there's primary, secondary, and tertiary bundles, which make up really the tendon. On the outside here, you can see there's some connective tissue, and it's surrounded by a tendon sheath. And that'll be important later. And these are an important component of the musculoskeletal system to transmit forces to the skeletal system. So you may be wondering, what's the difference between a strain and a sprain? I'm glad you asked. Sprains are partial tears in a ligament, and mild sprains usually heal over time. Severe sprains with complete tears can require surgery. The example here, once again, is the ACL of the knee. A strain is a small or partial tear in the muscle and tendon, often caused by overuse or injury. A mild strain usually heals on its own. Severe strains can require physical therapy. And here's a good picture just to differentiate between the two. So the strain, you can see this is the Achilles tendon. This is your gastroc muscle, attaches to your heel. And then a sprain is going to be more of ligaments, and this would be in your ankle. So what is the role of the tendon?
Oh, easy.
is to absorb mechanical load up to 8 times body weight. So there's 4 different types of load. I really like this infographic. It's from the British Journal of Sports Medicine. I really like it. And let's look at the first one here, the elephant. Okay, so it's a good idea here. Compressive is a tendon being pushed against a bone. Okay, so it's being compressed. The second one here is simply cycling. So the movement of the tendon sheath, which we just talked about, which is that outside part, can cause some friction. So this is the ankle. It's going to move up and down as you're cycling. The third one is tensile. So think of a spring. You're storing and releasing energy for power. And then a combination is going to be movements in more than one direction. These are going to be general functional activities, and especially athletes, if you think of soccer players, football players, they're going to be moving in more than one direction. So which tendons?
Chris,
yes.
Is it possible to make this full screen?
I am not quite sure on that. It looks to be full screen on my end. So if you're on a mobile device, you may need to flip your phone or iPad or something.
I'm on a computer.
Sideways.
Not.
I think we have what we have, unfortunately. So we're going to have to keep plugging away here. Otherwise, I'm going to have to unfortunately kick everybody out of the meeting. So hopefully you can at least generally kind of see, there won't be too many really, really small details here anymore. So which tendons of the bodies have the most dysfunction? So we're going to start kind of from the lower body and move on up. So we have the Achilles, which is in your ankle, the glute med, which is in your hip, the adductor longus, which is also in your hip, the quad, which is in your knee, also known as jumper's knee, the rotator cuff muscles, which are in your shoulder, and the extensor carpi radialis brevis, which are in your elbow. So these tendons are responsible for absorbing mechanical load from your body repetitively throughout the day. Tendons in the upper body can become dysfunctional as well, but it's important to note a majority of the tendons here are in your lower body just because they are supporting your body weight. So what is tendinopathy? So I'm sure y'all came here to ask this question, what is it? So the definition is it's a common clinical condition characterized by painful mechanical loading of an involved tendon associated with significant limitations in daily or sport activities. So looking at the picture, if you recall from our earlier slides, tendons are made up of collagen fibers, and they can become disrupted and disorganized, as you can see here in this picture. What really proliferated is the research and just knowing a lot more about this, which we're really going to get into here in a minute. So the history of tendinopathy research. Keep the function in back of your mind here. It's very important to note, and as a point we're going to come back to later. So the 1990s, so not all that long ago, inflammation is a main driver of tendon pain.
I'll take care of it. You just keep
going. Treatment is focused on anti-inflammatory medications and corticosteroids. In the 2000s, an addition of degeneration with inflammation was an increasing amount of research. And here in the 2010s, an increased understanding of tendons has led to improved treatment strategies based on tissue function. And that's really the important part there. So what's the difference between tendinopathy and tendinitis? I'm sure you've all heard of tendinitis, right? And this tendinopathy concept or this word may be something that's different. Well, itis means inflammation. That's kind of the root word, inflammation. So numerous studies demonstrate actually little to no inflammation is actually present in the tendons, exposure to overuse over time. So we're going to put a big X on that, okay? Traditional treatment modalities have had limited success in treating chronic and painful conditions arising from overuse of tendons. Tendinopathy is more of a continuum. It may involve an initial period of inflammation, so there is some inflammation followed by generalized tissue breakdown. Overall, the tendon gets weaker and functional load tolerance decreases, and there's an increase in pain. So this results in tendon degradation, weakness, and pain. So what's the difference between acute versus chronic pain? So acute, and this is talking a bit about inflammation here, is generally less than 3 months in duration. So these are where you're going to see redness, warmth, swelling, and pain that occurs with lower level of activity. So this would be more of the tendinitis. Tendinopathy tends to occur more so greater than 3 months out from injury, and there's actually no swelling, redness, and warmth. Pain tends to occur after the onset or after completing higher level activities. Think jumping and running, but not necessarily just walking day to day quite as much. So let's take a look here. You can see here, hopefully on the picture, I know it's kind of small for some of you, of two different tendons. The one here on your left is going to be healthy. The one on your right is going to be labeled as tendinopathy. The one on your left, you can see there's some blue fibers here and there's white, where the collagen fibers are densely packed and organized, leading to high load tolerance. Normal tendon tissue has a low collagen turnover. All right. You can see there's not a whole bunch of red, which is going to be your vascularity, and there's not too many nerves. Now let's take a look at the tendon here on the right. It's disorganized. There's collagen's kind of not going all in the correct direction. It's going every which way. You'll notice there's actually increased blood flow. There's increased vessels and nerves. This actually leads to decreased tendon stiffness and strength. There's actually increased cell temperature. Note that one of the things is blood flow. Previously, it was thought back in the 90s and 2000s, hey, poor blood flow is part of what's going on here in these tendons. Well, hey, we actually know now that's not really the case because there's actually excessive blood flow and there's excessive nerve growth. An important point here in the picture on the right is it shows the entire tendon is kind of being orange or dysfunctional. That's usually not the case, and there's actually a lot of healthy tissue out around the outside of that tendon. So what are some risk factors for tendinopathy? Adipose or fat tissue, which we know, and there's more and more research coming out, causes chronic low-grade inflammation. Genetics, there's possibly some association, although it's not fully understood, with the COLA1 gene mutation. There's going to be more research upcoming here, I'm sure, in this decade on that. Age, tendinopathy is most frequent in between the 3rd and 6th decade of life for the lower extremities, 50 years and plus for the rotator cuff. Overuse, the start of something repetitive, a new job, a new sport. How much time you have between doing whatever it may be you're doing, and how much time your body has to rest, and the intensity of what you're doing. Meaning, are you just walking from your couch into your bedroom, or are you going and running up a hill? So this all leads to the question, where's the pain coming from? And it's complicated. Tendon ruptures occur in people who don't have any tendon pain. But why? We think maybe the tendon pain underneath the structure may be disorganized, but a lot of those people don't have any pain at all. One of the things that we mentioned earlier is that with hypervascularization, meaning there's just more blood flow and more nerves, because there's more nerves and more nerve endings in the tendon, these can lead to perhaps some more pain. There's possibly some changes in the cell function. There's different markers known as substance P, which you may have heard of, and calcitonin gene-related peptide, which are involved in pain transmission. So this is all really good information to know, but what does all of this have to do with donuts and holes? Well, I'm glad you asked. So the role of tissue loading, strengthening, is to stimulate repair and remodeling in not only tendons, but in many different tissues of the body, including cartilage. My colleague Nick, who also works here up at Profit Rate, is going to be giving a presentation on this in April, so stay tuned. It's going to be really, really interesting. The research has actually found it's easier to build strength around the disorganized tissue. Think this is the disorganized tissue, the whole, but the focus should actually be placed on the donut, the good quote unquote tissue, because this is something we can actually affect in your function and be changed in a positive way. Thus the saying, treat the donut, not the whole. Now, I cannot take credit for that saying. There's a researcher in Australia, her name is Jill Cook, and she is like the pioneer of tendinopathy and all things related to this. So that is her saying. I'm not taking any credit for that. Speaking of Jill Cook, we're going to transition here a little bit in the presentation to some more practical things. So we've been looking at a lot of things at a physiological, at a cell level, but let's look at things a little bit more so here at a practical level. So top 10 things here you should not, and the emphasis in red with bold letters is not do if you have lower limb tendon pain. And this is actually adapted from Jill Cook, who has her PhD at La Trobe University in Australia. Remember, these are things you should not do. All right, number 1, absolute rest. Do not absolutely rest. Complete rest decreases the ability of the tendon to accept load. Within 48 to 72 hours, you will start to demonstrate decreased strength and decreasing function for your body. There's a reason total joint replacements get moving on the same day, usually within like 6 hours of surgery. All right, so I'm going to X out the bed there. All right, only with the underlying complete passive treatment. So remember, don't only complete passive treatment. Electrotherapy and ice will only temporarily relieve symptoms. Now, there's something to say, if you're really, really hurting and in a lot of pain, this may help manage your symptoms. So I'm not saying don't do these at all, but don't have them be the only thing you do. Remember, pain is likely to return when the tendon is loaded. Have an injection therapy. There has been increasingly amount of increased research to say injection therapies demonstrate poor outcomes with injections alone. All right. Number 4, ignore your pain. Do not ignore your pain. Pain is protective, and it's a way of telling you the load is too much on your tendon. So your body is telling you something, don't just ignore it. All right, stretch your tendon. This can be a little controversial. So stretching, what we know, if we go back to the infographic, stretching adds compressive load. It can be very, very painful on standing. So instead, we would recommend to massage your muscles if they're tight, but not the actual tendon. Because you remember, if we go back to that picture, that tendon has the fibers going every which way. It's got increased nerves. If you stretch that, that's actually going to cause some more irritation. Another thing you shouldn't do is massage your tendon. If you think about something in your body that may be really irritated, the worst thing you want to do is kind of rub on it, but that's instinctively what we want to do, right? But the message here is, hey, don't massage that tendon. The muscle, hey, that's okay, but the tendon, avoid that. Number 7, be worried about images of your tendon. Evidence says that tendon can take loads if managed correctly, and we'll talk about that a little bit more. Don't let the MRI and ultrasound frighten you of what your tendon may look like in the inside part of the structure. Now, it's important to know, hey, it's good to have that information on hand. When my patients bring in an MRI or a CT scan, I take a look at it, and it's important for me to know how much load that tendon can take, but guess what? We're still going to work on strengthening. Number 8, don't be worried about rupture. Pain is protective of your tendon. Remember, most people that rupture a tendon have never had pain in their life in that particular tendon. Number 9, take shortcuts with rehab. There's no shortcuts for strengthening of a tendon. Strength takes at a minimum 6 to 8 weeks to build up, so there's nothing you can really do to rush that process. And then have an understanding of what loads are high for your tendon. So make sure you understand that tendon is like a spring, changing direction, sprinting, those things are going to be a really, really high load to your tendon, and those may not always be appropriate for you if you're having a lot of pain. So let's talk about some guidelines for exercising with tendon pain. The focus is going to be here on the lower body, but these principles can generally be applied to the upper body as well, and they are general guidelines overall. So understand tendon behavior. 24-hour behavior is a guided tendon load and overload on a day-to-day basis, meaning how you feel today is how your tendon responded to yesterday's load. More isn't always better. No pain, no gain is actually not true. So let's talk a little bit about pain and soreness. So you can see here at the bottom, this is called the numeric pain rating scale. And you probably, if you've gone to a doctor's office, they've asked you, hey, on a scale of 0, no pain, 10, the worst pain possible, how bad are things hurting right now? So understand with tendinopathy and tendon pain, when you're rehabbing, a small increase in pain, if temporary, is actually okay. And that means generally no more than 2 out of 10 increase on the 0 to 10 pain scale. Meaning, if your tendon is hurting 2 out of 10 pain at rest, it's okay if it goes up to a 4 out of 10, but that's only temporary. pain levels should not be higher 2 days after a workout than baseline, no matter what. So if you're on day 3, if today's Monday, you worked out today, and Thursday, your pain is still higher than baseline, hey, guess what? That means that workout was too intense for that particular tendon, because that is outside of the constraints of what's going to be helpful. Absolute rest is detrimental. So remember, there's this balance, right? If you don't want to do too much, you don't want to do too little, you want to be right in the middle. Let's talk about that a little bit more here in detail. There's a graph. There's a lot going on here, so let me try to orient you to it. The graph describes protein making, synthesis, here you can see on the left side, versus protein breakdown, degradation, after exercise. So this is time after exercise. So you can see at 1 day after exercise, you are actually in the negative, which means your body is actually breaking down protein. So after 1 day, you can see here where the green arrow is, you start to have a net positive of building protein, which is building up your strength, building up muscle, and building up those collagen fibers. As you look from the workout, you actually continue to build strength up to 3 days after that workout. But can you see why it's important for you not to overload, and why we're talking about this 24-hour pattern? Make sure that you're not doing too much too fast and without enough time to rest. So this is kind of really a physiological level of why rest is really, really important. Let's talk a little bit about load management. So you can see here in the infographic, current capacity here is at the bottom. So in very small steps, you're going to eventually be able to get to your required capacity to do whatever you want to do, which is run, do higher level things, sprinting, jumping, so on and so forth. So as the load of your tendon over a program increases, the pain should generally go down. The pain should decrease. The addition of speed and energy storage and compression can increase symptoms. So go slow, ramp up your intensity slowly. Make sure to monitor how you're feeling throughout your workout, along with how you feel after. Remember that 24-hour pattern very closely. So we're going to do a little bit of a case study here on the Achilles tendon. And we're going to just look at some general guidelines of how to strengthen and load it in 4 phases. And this is based on a paper from Siebernickel in 2020. And we're going to be talking about the first phase is going to be going from high pain and low tolerance to eventually low pain and high tolerance. Okay. So the first phase here of this for the Achilles tendon is going to be the symptom management phase. So the Achilles tendon, which is the one right in back of your leg that connects to your foot bone, to your gastroc, your calf muscle, you're going to have pain with all activities. So you're going to have difficulty raising your heels up like the picture is showing. The goals: start to move, understand the nature of the injury, and monitor pain. Remember, absolute rest is bad. Intensity of exercise: slow, controlled motion. Perhaps you can even start in seated up to full body weight. So think of a seated heel raise, right? Body weight's not on it. That's just to get the tendon moving again. Remember, absolute rest is the worst thing you can do. Let's get you moving just a little bit. An isometric heel raise. An isometric basically means you're not moving. So you're just going to be pushing against something without kind of really moving. And that's going to be where you're going to be doing something with a really long hold, but very low reps. So 5 repetitions with a hold up to 45 seconds for each rep. Time frame. So it's going to be 1 to 2 weeks or longer if needed. You're going to complete these exercises 3 times a day. Remember, they're low in intensity, so you can complete them frequently. You can modify things like this where you're not kind of going through your full range of motion. Phase 2, recovery. Achilles presentation is going to be, you're going to have pain with exercise now. You're going to have pain with morning stiffness, but you may be able to walk around throughout the middle of the day without too much discomfort. Your goals are now really to start strengthening and improving the load tolerance of the tendon. Intensity of exercise. You're going to still want to have speed of movement being slow, but you're going to want to add weight when just your body weight is easy. So an example here is going to be a 2-leg raise from a step, or a 1-leg raise from the step, where you're really kind of using your body weight. And then if you say, hey, that's easy, you're going to add some additional weight. Look at the sets and reps though. You're going to increase the number of sets, but you're going to go low in the reps. What does that mean? That's going to mean you're going to start to get into some heavier weight to build up the collagen tissue. Time frame, how long is this going to go on for? 2 to 5 weeks or longer. One other important point to note here is you're going to be completing this only 3 times a week. So remember, if you do this every day, that protein synthesis is going to be negative. There's a high risk of injury. Your body needs time for rest. Rebuilding. The Achilles presentation, you're going to have occasional morning stiffness and minimal difficulty performing something as simple as a heel raise. Your goals are going to be increased strength training, and you're going to start to run and jump. So the intensity of the exercise is going to continue to go up. You're going to increase weight, but you're also going to increase speed, but not at the same time. So you would do one first and then something other. An example would be quick rebounding heel rises, and then eccentric heel rises on a step, meaning you would go up quickly and then slowly down with weight as pictured here. Time frame, 6 to 12 weeks or longer. Remember, muscle tissue takes 6 to 8 weeks. For some people, if you have more comorbidities, you're overweight, you're diabetic, you have high blood pressure, it's going to be more on the 12-week side. If you're healthier and younger, it's going to be more on the 6-week side. You're going to want to complete these exercises maybe as little as 2 times a week if they're really intense. And then the last phase is returning to sport, whatever that may look like for you. So your Achilles is not really going to be stiff and you're not going to be having much pain. These are going to be more of maintenance exercises and more of sport-specific exercises. You should not have any additional pain by this point in your rehab. Intensity of exercise, you're going to progressing speed and directional changes if you're a soccer or football player. Plyometric training, which is just really fast motions. Think of that example that we talked about, the tendon as a spring. So as you are going to be sprinting, you can kind of see that tendon is going to be acting as a spring, controlling the rest of your body weight on it. Time frame, man, this is going to take 3 to 6 months or longer if needed. And once again, you're not going to be doing this every single day. You're going to probably do this 2 to 3 times a week. And there's a lot of nuance. So I understand there's probably folks out there, you're like, man, that was really, really general. Yes, I know. So there's a lot of nuance of, when somebody comes to me and says, hey, this is how I'm doing, I'm taking all these different factors into account to come up with a customized treatment program for them. So these guidelines are good, but know that I don't expect you to kind of have every single exercise at every single dose correctly. That's kind of what we're here for, to say, hey, this is what you should or shouldn't be doing. But these are just some general guidelines here for the Achilles tendon. Of course, every other tendon in the body we've talked about does respond a little bit differently and has a little bit different regimen than what we've just talked about. But I hope that's been helpful for you. So we're getting here to the end of the presentation. I hope it's been useful for you. And there's just some take-home points here. Remember, not all tendons are created equal. Treat the donut, not the whole. So focus on the healthy tissue, not the dysfunctional tissue. Load the tendon depending on the tendon's response and symptoms. This applies to both the upper and lower body, and understand the tendon's 24-hour behavior. Remember, no increase in pain greater than 2 days or more than 2 out of 10 from the baseline level. So I have some references here from the different journals and articles I've used to make this presentation. And I'll open the floor up here to questions. There's my contact information. I'm just going to leave this up here on the slide. So if you have any further questions, email me, you can call me, and here's where I'm located as well. So I'll turn it back over here to Angela for now.
All right. So here we're going to pull up the questions. Here we go. Okay. Yes. So this will be recorded. So for all of you who have participated today, I will send you a link once we have the recording up on our YouTube channel. Also, I noticed that, with the screen sharing and things like that, that a lot of the images may have been a little bit smaller. In the recording, I will make it so that those images are larger. So if you are having difficulty during this time, seeing some of those images, once I send the recording, hopefully you'll be able to see those a little bit clearer. So let's see. Okay,
Yeah, we've got a good number of questions here. So I'm just going to kind of go in the order they came in. When should surgery be considered? Yeah, good question. We didn't really talk about surgery a whole bunch. To me, that is kind of a last resort. And I also think if, talking with some surgeons here in the Charlottesville area, I think that's also really their thing is they'll really want you to try rehab and try, different types of things, maybe some aquatic therapy. And if those really aren't gaining any traction, then really, surgery is your last option, knowing that after surgery, there's a lengthy rehab process as well, where you'll most likely be in a walking boot, not weight bearing, for usually a couple of weeks at least. So really tend to be really conservative, and it's really where you feel like you've exhausted all your options, to where you feel like you can't do anything anymore with that. So good question. Another question here is, what sports should be avoided for acute Achilles tendonitis? Really, once again, that's kind of a load tolerance question. I would first start, and I start with my patients, hey, how do you do going up steps? How do you do walking? And if the answer to that is, man, I have a lot of discomfort, I would say, hey, hold off on any sort of aggressive sport activity for the time being, not forever, for the time being, until you can do regular daily activities around the home, walking, going up steps without discomfort, and then we'll talk more about sports. So that's really kind of, you want to make sure that you're not kind of just saying, well, I'm just going to push through it. That's really not the goal of this. Remember the tendon healing and all that process as well. We have another question here regarding don't stretch the tendon. I thought stretching was critical. Yes. So with this, as we went through this, there's been a lot of research lately to say that stretching actually causes more irritation and pain. However, there's a time and a place for stretching. It tends to be mostly when you're not having a lot of pain and irritation. It'll be more so when you're having less pain and you feel like things are maybe a little bit more stiff. But if you're like having, 7 out of 10 pain, we'll say, stretching is not going to be the first thing I'm going to recommend. But if you're saying, hey, I have no pain at all, I just feel like things are a little bit stiff, go ahead. Stretching is not going to bother you at all with that. So there's definitely some nuance to that. And don't hear me saying all sorts of stretching is wrong. That's not what I'm saying. I'm just saying there's a certain time and place when that can cause increased irritation. Another question here is, does a particular exercise up to 3 times one day, then hold off on that exercise for 2 to 3 days? That's a good question. So with that, there's different phases. So if you are really, really hurting in the tendon, there's going to be the isometric phase, which is generally going to be very, very low in terms of intensity. That's why you can do those 3 times a day, every single day, because they are so low in intensity, they're not really causing that much protein breakdown. Whereas when you get to some of the higher intensity exercises, those cause more protein breakdown, and that's why you need to take more time to rest. So in the first phase, I'll tell my patients, hey, do these exercises every single day, because they're generally very easy. But as they get more intense, that's when I'll say, hey, back off to the 2 to 3 times a week. So they're not kind of at the same time. So hopefully that answers that question there. Another question here. In my research, what have you discovered about the use of statins related to tendinopathy? There's definitely a negative effect in terms of use of statins in tendinopathy. That is definitely another risk factor involved as well. So that's definitely something to consider as well. And there's more evolving research that's coming through with that as well. All right, so another question here on stretching. When's it safe to add back into the mix? And this is just a good general question. I get a lot of patients say, hey, when is this or that particularly safe? And I'm going to kind of route you back to the tendon healing and the tendon loading guidelines of generally, if you were to do a stretch, okay, how does it feel when you do it? Does it hurt? No. Okay. And then the next day, how do you feel when you're walking? How do you feel when you're doing your regular activities? Does it hurt? No? Okay, then it's safe to do. If any one of the answers is, yeah, hey, that still hurts a little bit the next day, that means you're probably not quite ready to do that stretch, all right? I'm guessing this is, how does tendinopathy different from tenosynovitis? So tenosynovitis is going to be on the outside part. So you have your tendon, you have your fibrils and your primary and tertiary bundles. And then you have the sheath on the outside. And that's actually going to be involving the sheath and irritation between the sheath and the actual tendon. There's actually quite a number of different molecules and different substances that cause that to glide back and forth. And it's the actual irritation between those substances, which I didn't really touch a whole bunch on But that is something where if you're, cycling, for example, a lot, that is something where you would see that a little bit more. Okay. I have a question here of having pain in the left adductor muscle for years, and then having pain at the knee in the patella, which is the kneecap. This person reports playing tennis and hiking through pain. I just started seeing a personal trainer who's having me lift more weight than I've ever done. I fear I'm going to injure myself. Yes, this is something that I've heard that's quite common, and I think this is a good conversation to have with the trainer you're having of what you're doing, how you're feeling when you do it, how you're feeling afterward, and then how your body is responding to that. And I think it's just using those same principles of saying, hey, I'm really hurting. I'm hurting more than 2 days. That's a good guideline that you're probably loading too much. And really just having those principles and making sure whoever you're working with is kind of on board with those things, and really making sure that you feel comfortable with what you're doing. I like to say, you're the expert at your body. So when you come in and you see somebody, if you see me here, I really trust that you're the expert at that. And I'm just really here to help guide load management. And I'm just here to give you some general suggestions of what to hold off when and when to reintroduce things. So I would definitely make sure to have that conversation, with your trainer to say, hey, these are some things I'm concerned about. I've never done this much weight, and this is kind of how my body feels afterward with that. We just had another question come in here. How do you decide on appropriate therapy when multiple repairs are done on the shoulder, and some require 6 weeks of no movement and others require immediate movement? That's a really good question. Without knowing really the specifics of your surgeon and the surgeries completed, I can't probably give you any particular specifics. I will say if it's been multiple surgeries done on the shoulder joint, most times we're going to end up erring on the cautious side or the conservative side of not doing too much too quick, because the tissue is really repairing and it's not able to tolerate a whole bunch of load right away. So in those cases, in terms of after surgery, I'm going to treat somebody very, very differently than if you're coming in, usually not with the surgery. Once again, with the nuances of what's been done and what your surgeon, would like to have done, and then also really how you're presenting on the first day you would come in. So hopefully that answers that question for you. Anybody else have anything else? Any other questions out there? These are all really good, insightful questions, and hopefully this has been good for everybody else to hear the questions as well.
All right. Well, I think we'll wrap things up for today then. And again, there's Chris's contact information. You all also have my contact information available, so feel free to reach out to us. And I will also be sending the information to you all once we get the recording up and running. So thank you all so much for joining us today, and we look forward to seeing you again in the future. Thank you.
Yeah, thanks everybody for jumping on.